The final Fellows Journal Club article is Treatment of 213 Patients with Symptomatic Tarlov Cysts by CT-Guided Percutaneous Injection of Fibrin Sealant by Murphy, Oaklander, Elias, Cathuria, and Long, originally published online September 24, 2015. Tarlov cysts are a dilemma. The general thinking is that they are inconsequential. However, some patients can be symptomatic. This cohort study assesses outcomes in patients who underwent CT-guided aspiration and injection of sacral Tarlov cysts at Johns Hopkins Hospital from 2003 to 2013. A total of 289 cysts were treated in 213 consecutive patients, with 83% followed for 3 to 6 years. 1 year post-procedure, excellent results were obtained in 104 patients, with 54.2% of patients followed, and good or satisfactory results were obtained in 53 patients, or 27.6%. It is a real pleasure to have Dr. Kieran Murphy, lead author on this paper, joining us in the podcast to discuss his interesting work. Dr. Murphy is Professor of Radiology and Director of Clinical Faculty at the Techna Research Institute. Dr. Murphy, welcome to AJNR podcast. Thank you for joining us today.
Thank you. It's a pleasure to be invited to do this.
I'm going to lead with a spoiler, Tarlov cysts. They are more than meets the eye. Tell us about Tarlov cysts. They're apparently more than just incidental findings?
Yeah, in fact, it's about 5% of female back pain. These cysts occur in the sacrum, usually at S2 and 3, predominantly in Caucasian women, and they cause S2 and 3 radiculopathy, which can be incredibly debilitating. And one of the most frustrating things for the patients are that neuroradiologists or radiologists often say that they're incidental asymptomatic findings, because somehow anthropologically this phrase has become a conditioned reflex. But there's never been a paper.
Well, maybe we didn't know enough about them.
Yeah.
But we're learning. And why women more than men being affected?
So it's clearly
the prevalence different?
Clearly, there's a genetic predisposition, so we've also studied these patients genetically, and I have genetic data on 24 patients with extremely interesting findings that we're just repeating at the moment, but it looks like we've also identified a specific genetic defect related to this abnormality. These lesions occur in a wide variety of genetic disorders, including Marfan's, Ehlers-Danlos, Loeys-Dietz syndrome, tuberous sclerosis, neurofibromatosis, but then there's a subset with a very specific appearance that occurs related to a specific genetic defect, which I'm not going to mention till I repeat all our tests, but it looks like there's a specific connective tissue disorder related to this abnormality.
Interesting. So that the pathophysiology may be different between different etiologies resulting in Tarlov cysts.
The word Tarlov cyst describes a specific subset of perineural cysts and refers to the entity described by Tarlof in the 1920s based on sacral dissections that he performed at McGill University in Montreal. There are a wide variety of meningeal dural abnormalities that occur in the sacrum, and some of these are congenital large sac-like diverticula, and other of these are small cysts that look like a bunch of grapes that occur predominantly at S2, 3, and 4. And as I say, predominantly in women, Caucasian women. And they cause bony erosion of the lamina and the vertebral body. Sometimes they extend through the anterior sacral neural foramen into the presacral space, and they can be severely debilitating, causing either perineal pain, lower extremity pain, or bowel and bladder dysfunction, or all three if people are particularly unfortunate.
So you mentioned some of these other terms that get thrown around and I think a little bit confused with Tarlov cysts in terms of perineural cysts, nerve root sleeve cysts, meningeal diverticuli. What's the take-home message to help clarify things for the interpreting radiologist? How can we be helpful?
Right. This paper relates to a patient population with narrow-necked cysts that are Tarlov cysts that I treated, or my colleagues treated, by fibrin glue injection. There are very wide neck cysts that are not treatable with this technique because the fibrin would extravasate essentially into the subarachnoid space. And that would be bad. People would get arachnoiditis, etc. So I'm speaking in this paper specifically about the narrow-necked population.
Sure.
There are a wide variety of meningeal and dural abnormalities in the distal lumbar spine and sacrum. The wide-necked sacral dysplasia-type cysts are congenital and usually related to connective tissue disorders, like Loeys-Dietz, Marfan's, Ehlers-Danlos. The Turnoff Cyst group are different. These are narrow-necked clusters of cysts that look like small grapes on the sacral nerve roots, and these appear to occur in the region of the dorsal root ganglion, where the cyst and the arachnoid granulations in that region appear to have a causal relationship. These cysts can be large. They can be 5-6 centimeters in size. There isn't a specific size that makes people more likely to be symptomatic or not. It's possible to have a 5 or 6 millimeter cyst that causes symptoms, but most of the ones that I treat are over a centimeter in size and have laminar erosion associated with them. The bigger the cyst, the more the bony erosion that occurs, and the greater the likelihood of symptoms. Sometimes a right-sided cyst is so large it causes left-sided symptoms from nerve compression. The pain appears to arise from the dural distension. The nerve may be... Yeah, I think it's a referred pain from dural distension and periosteal irritation. And some of these people get such large cysts that they have almost whole body erosion, and they have sacral insufficiency essentially, because perhaps S1 or S2 will be replaced by CSF and dura. So they're very challenging.
Is the narrow neck, topologically, that space is still connected to the subarachnoid space and contains CSF, though, right? Even though in your paper you describe the late wash-in of the contrast that you'll see.
There's another paper that we published in Neuroradiology in January, in fact, and there we define the anatomy of the neck. In the neck, there's a ball valve, and that ball valve phenomena is caused by arachnoid granulations, which appear to be enlarged.
Interesting.
And these occur in the region of the dorsal root ganglion.
Mm-hmm.
Now, the number of arachnoid granulations increase from the calvarium all the way down to the sacrum, and they're seen with increasing frequency at S2 and 3, and we confirmed this by doing anatomic dissections in the anatomy lab in Geneva with my colleagues in anatomy there who were fantastic, Dr. Fazel and Dr. Stimek.
If there are several levels where there are cysts, do you treat multiple levels at once, or how do you determine which level is the symptomatic level?
Well, basically, it depends on the patient's dermatome distribution of their pain. Is it S2? Is it S3? Is it left or right? Sometimes it'll depend on the size of the cyst. The larger the cyst, the greater the probability it will be symptomatic. And also, as I did today, I will do functional blocks in the cyst using Marcaine to see if I can get rid of the patient's pain.
Sure.
And then go step by step. It will take sometimes several visits to identify the culprit cyst.
In terms of outcome, is the effect immediate? It sounds like it is if you're putting anesthetic in and people are getting immediate relief.
With Marcaine, it's very interesting. They can get immediate relief. With fibrin glue, the longer the patient has pain, the longer it takes for them to get better. As with anything, like compression fractures, the more chronic the cycle of pain has been present, the longer it will take to give them pain relief. Fresh vertebral fractures respond much quicker than a 6-month-old fracture. Many of the patients I see have had pain for 13, 14, 15 years. They'll come in on Cymbalta and Neurontin and Methadone, and they'll have been told they're mad and dismissed. Often that dismissal is initiated by a radiological report saying these lesions are asymptomatic and incidental. And my hope for this podcast is that we prevent radiologists from saying those words often for which there is no basis. And we just prevent that being said.
Yeah, well, we're certainly trying to educate readership of AJNR. I think it's an important paper that you guys have out, so we're pleased to have you on the podcast. Do you know what the long-term benefit of fibrin injection is?
We followed them for up to 5 to 6 years. This is a group of patients who are very well followed. They're very connected. They have very active help groups like the Tarlov Talk, Tarlov Help sites. These groups have a wonderful organization that provides research funding through the National Organization for Rare Diseases, and they're very connected, highly motivated. So we have long-term follow-up on these folks. Yeah.
And the outcomes are long-lasting, or do they have to come back for repeated visits?
A small number will come back for repeated visits, about 25%. And I don't mind that because I can always do more, I can never do less. The fibrin will cause some inflammation. People's pain can transiently increase for 3 or 4 or 5 weeks. So I would prefer to see people more than once and then do another procedure than make them incredibly inflamed and miserable the first time.
Sure. Well, congratulations on a very nice paper with a large cohort of patients that brings this potentially very clinically important entity to light. Dr. Kieran Murphy from the Techno Research Institute, I thank you for joining us on the show today and sharing your experiences treating these patients.
Thank you. It's really important for the patients to have their problem taken seriously. Thank you.
Absolutely. And thanks to our listeners for tuning in to this edition of AJNR Podcast. We'll see you next time.